And viewers, and a warm welcome to our eminent panelists who have found time to join us for this discussion despite their immensely busy schedules. With nearly 39 million COVID infections and more than 1 million deaths, the world is facing the biggest humanitarian crisis of the century. 214 out of the 235 countries and independent territories have been impacted by this deadly virus. However, despite these mind-numbing and sobering statistics, there is a silver lining to the COVID cloud. The almost unprecedented manner in which the global community has come together, be it the country governments, researchers, manufacturers of vaccines, pharmaceuticals and diagnostics, country governments, philanthropic organizations, multilateral donors, non-governmental organizations, and more importantly, the healthcare workers who are at the front line of fighting this epidemic, gives us hope that this too shall pass. In the absence of a standardized testing regimen and a vaccine, testing remains our best option and is in fact the first line of defense against COVID-19. Most importantly, it is actionable now. It has been shown across the world now that testing, tracing, and isolating confirmed cases works. In fact, testing is something which will also enable the implementation of test and treat strategies once appropriate treatment regimens become available. Testing also means we understand that who has been exposed to the virus so that we can build a picture of the population immunity, something which is going to be critical for the targeted deployment of vaccines. From a diagnostics standpoint, while RT-PCR remains the gold standard, the recent introduction of rapid antigen tests has allowed the countries to ramp up testing in a big way. Challenges, however, remain as far as the sensitivity of the rapid antigen test is concerned. That is, the currently available rapid antigen test is concerned. In fact, there is very clear guidance now from both the WHO as well as the Indian Council of Medical Research that for the COVID antigen test, those who are symptomatic and test negative on the RAT must necessarily be confirmed or be retested on the PCRs to confirm the status of infection. Antibody tests, however, are recommended only for surveillance currently and to determine the extent of spread of the infection in the community, in the vulnerable communities, as well as the population at large. Of late, there has been a significant progress in the development of new diagnostics for COVID, and there have been significant investments, for example, by the Government of India. You see on the left, there is the CCDA or the CCAMP COVID-19 Innovations Deployment Accelerator, and there is a whole bunch of other initiatives that are being supported by the government in various forms and shapes. The private sector and the corporate community, as well as the philanthropic donors and foundations, have also come together to support a whole lot of R&D efforts within the country to drive indigenization of diagnostics. There is a very healthy antigen RDT pipeline, with more than 14 to 15 tests in various stages of development. The scene really looks encouraging. And we are also seeing, from a molecular perspective, that there are developments, for example, the LAMP-based assays, which are now becoming available, and the very recent announcement on the CRISPR-based test, that is the Feluda. And with all of these tests, there is a significant hope that we will be able to decentralize the testing to the extent possible. However, translating an innovative pipeline into testing, it does require coordinated action at the global, regional, and at the country level. It is absolutely critical that clear guidance is provided to countries on the deployment and the uses of these tests. In order to overcome the manufacturing and the supply chain constraints, there needs to be a collaboration in global procurement in order to ensure equitable distribution of tests across the countries. At the regional level, absolutely critical to increase awareness to accelerate the uptake. And this needs to be tailored in order to support the countries recognizing the situations on the ground. And at the same time, critical to develop capacity, critical to develop capacities of the health systems by training in the healthcare workers in order to deploy these tests. At a country level, it is critical to have on-the-ground support in terms of how to rapidly and effectively deploy the tests, and more importantly, lessons learned to inform the development of the upcoming pipeline of the new products so that they can better serve the user needs. In response to in understanding and recognizing these challenges, there has been an unprecedented global effort in the form of the ACT-Accelerator, or the Access to COVID-19 Tools Accelerator. This is a new groundbreaking global collaboration to accelerate the development, production, and equitable access to COVID-19 tests, therapeutics, and the vaccines. From a diagnostics standpoint, the diagnostic pillar is co-convened by FIND and the Global Fund, the WHO, in the center of the action. The diagnostic pillar has 4 focus areas. That is accelerating the development of high-performing, affordable, rapid diagnostic tools and creating robust digital data, preparing the markets to accelerate the implementation through simplifying regulatory pathways, market shaping, and enabling scale-up of manufacturing, supporting the cost of test procurement and deployment in the low and middle income countries to overcome constraints associated with the supply chain, and last but not the least, strengthen the health systems and build country capacity for rapid and effective deployment of the tests as they become available. There has been, the ACT-Accelerator has been in place for the last few months, and there has been tremendous progress that has been made so far. And more importantly, the first antigen rapid test has been added to the WHO emergency use list, and 5 active applications are already aligned to the assessment pipeline. 120 million antigen rapid tests have been secured for the low and middle income countries for the next 6 months at a price of $5 per test, with an opportunity to further lower the tests. Interim guidance has been published by WHO on the use of the antigen rapid tests. Another 19 million PCR tests and 8 million sample collection tests have also been aligned. And in addition to that, online training support has been provided to more than 18,000 participants across the world, including healthcare and social workers across 100+ countries. Coming to the project at hand, there has been a thorough understanding of the fact that the government of India has ramped up the diagnostic testing capacity across the country by establishing more than 1,500 labs in both the public and the private sector. However, while the labs are being added at a rapid pace, and the new diagnostic technologies and the infrastructure is also being expanded, there is an equally imminent need to ensure that the laboratory personnel who are being deployed for conducting these tests at the labs are appropriately trained, so that one can ensure the accuracy of the test results as well as the optimal utilization of the laboratory infrastructure within these laboratory settings. In view of this, the PSA's office, that is the Office of the Principal Scientific Advisor, in collaboration with the Bill and Melinda Gates Foundation, FIND has been able to launch a training project. And there are certain other partners like the TIFR Hyderabad and Mumbai, the National Institute of Immunology Delhi, and the Pan-IIT Association, through which we are implementing 5 work streams. The first work stream is an online training for laboratory personnel, and we are targeting around 1,000 personnel for this. In addition to this, the second work stream will have about weekly mentoring workshops with experts from regional national reference labs. There'll be a short upskilling training, which we plan to conduct on-site once the travel restrictions are eased further. Our partners are engaged in conducting a comprehensive 3-week pre-service training on basic molecular biology to prepare the lab techs to take on the challenges associated with COVID testing as well as other infectious diseases. And we are also going to launch a chatbot system for continuous online query in order to troubleshoot and respond to some of the common queries from the laboratories. So with this brief background, I would like to now introduce our panelists. A warm welcome to Dr. Kayla Lasseson, who is the Deputy Director of Infectious Diseases at the India Country Office of the Bill and Melinda Gates Foundation. Kayla's focus areas include TB, visceral leishmania, and lymphatic diseases. She was previously with the CDC India as the Country Director. Dr. Gagandeep Kang, a professor at the Wellcome Trust Research Laboratory and the erstwhile Executive Director of the Translational Health Science and Technology Institute. Dr. Kang is an eminent virologist who has worked on diarrheal diseases and a whole lot of other public health initiatives in India. She's a key contributor to the rotavirus epidemiology and vaccinology in India, and is also an elected fellow of the Royal Society. Dr. Anand Jaiswal, he's expected to join us shortly. I think he's busy with his patients, undertaking the duties that he's sort of supposed to. He's a leading pulmonologist in the country with more than 30 years of experience, and is the director of the respiratory and sleep medicine at Vedanta, the Medicity, Gurgaon. We also welcome Dr. Amita Jain, who's professor and head of the Department of Microbiology at King George's Medical University. Dr. Jain's research interests include TB and virology. She has 8 Indian patents and has published over 200 manuscripts. She's also the nodal officer for lab tech support and COVID testing for UP, and is in charge of the COVID testing lab at KGMU. So with this introduction, we will straight away dive into some questions for our esteemed panelists. So I'll start with Dr. Kang. Dr. Kang, in your mind, how do you think one can use the rapid diagnostic tests to influence India's screening and surveillance strategy, especially with the ongoing efforts in terms of completely opening the economy? Do you think there is a need to conduct large-scale screening of the workforce until we have an effective vaccine, or are there other ways of ensuring that the economy can be opened in a safe manner?
Thank you, Sanjay. I think that's a lot of questions wrapped into one. With any test, you really have to think about the use case for that test as well as the performance characteristics of the test. So far we've been using RT-PCR, and recently there's been a switch to having RDTs, and obviously there are advantages and disadvantages to both types of tests. So if we think about doing a test to get a diagnosis, then we really want to know whether a person has that pathogen at the time or not, and we would want a test that has the highest possible sensitivity and specificity and the shortest turnaround time. When we look at RDTs, there is a trade-off in terms of the turnaround time and the sensitivity of the test. But the turnaround time being short has an advantage because you can take immediate action. So if it is a question of using the test to look at transmission and potential risk to public health, then having an RDT available that allows you to make a decision and take action faster makes sense. So if we think about opening up the economy, what do we really want to do? We want to be able to handle disease, but that's what hospitals do. But we also want to limit transmission in the community. And RDTs have a huge role to play there, particularly when you think about companies and closed settings where you don't want infection to enter. In those kinds of settings, it makes a lot of sense to apply an RDT and apply it often. And in fact, I would challenge the assumption that if this is not to look at disease itself, but is to look at prevention of transmission, how much sense does it make to take every negative RDT to an RT-PCR? And this is something where there has been a lot of modeling done in other parts of the world. And the idea being proposed there is that multiple uses of RDTs in the same person might be able to give you results that are equivalent to RT-PCR when it comes to the goal of prevention of transmission. So back again, use case, performance characteristics determine what we should be doing with which test. Over.
Thanks, Dr. Kang, for putting it so succinctly. And I think, I couldn't agree more with you when you say, it is absolutely important to have these use cases, because RT-PCR, while it is the gold standard, I think it's definitely going to be difficult, not just for the low and middle income countries, but also the high income countries to subject, all of those negatives on the antigen tests to the PCR. So in that sense, I think it would make, good sense to have these use cases which can allow, rapid testing of the workforce as well as the other populations. I'll move to Kayla now. So Kayla, seroprevalence studies conducted now across the globe have indicated a higher spread of infection compared to the reported cases. In India also, we are now hearing anywhere from 25 to 27% infection basis surveillance done in certain targeted geographies. And then, in general population as high as, 7 to 10%. So in your view, how does the present status in India look? And with now the cases finally tapering, and I hope, they are tapering indeed. Do you think India is finally moving towards herd immunity? Or perhaps it's, in your view, it's too early to say that?
So thank you, Sanjay. I think the short answer is that it's a little early to say that, but maybe a little more explanation. I think certainly across India, there have been a number of seroprevalence surveys, and as you said, repeatedly, we find many more infections through serology than we are finding through symptomatic and asymptomatic testing through RT-PCR or rapid tests. So we know there are many more infections than we're finding through the normal routes. But we're finding 20% in some places and 6% in others and 70% in others. And so it's quite variable across the country. And what does that mean? And what does that mean for infection transmission? And if you go by the normal sort of what is the herd immunity, number that we should be looking for to believe we've kind of hit that peak by a very simple calculation, because the R naught of coronavirus is about 2.5. By a simple calculation, 60% of the population should be infected to reach what is called herd immunity, which really only means that the virus is, it's in a lot of people, and it will take longer for it to find another susceptible person. It doesn't mean there wouldn't be any more new infections. It just means it would slow down, of course. But that's a very simple way of looking at it, because first, this virus has a very big dispersion factor, meaning that some people infect many, many people, and other people don't infect any. And recent data coming out of India are showing that about 72% of individuals don't infect a single other person, and then others infect many. And that doesn't depend so much on the individual as it does depend on the circumstances, where that person is. Maybe they're out in markets, a lot of different factors, social factors, cultural factors, and biological factors that might lead to what are called these super spreading events or moments. And so a simple calculation of herd immunity doesn't quite work because of the way in which this virus works, which is not equal amongst all people. In addition, one's ability to transmit depends a lot on what your behaviors are, using a mask, social distancing, and everything else. And so there are a lot of arguments about that. Maybe 60% is too high, and that because it does operate with this dispersion, because some people are going to infect more than others, that maybe the herd immunity threshold is lower, 40%. Some people have said 20%. And I think we really, really don't know. And I think it's also very focal. So we might see in Dharavi that 67% are infected, 57% are infected, but around Dharavi, other places don't have that same level of infection. And so they are not at that same level of immunity. So I think it's just too early to tell. Certainly there are more infections than we know, but whether or not, places have hit what is herd immunity, probably pockets certainly have. But as a whole, I don't think the country can say that there's herd immunity yet.
Thanks, Kayla, for the great question. And also, I know it was a very loaded question and very complicated, but thanks so much for putting it in such a simple manner. And I think everyone is now understanding, and we are seeing new things about the virus every day. The way it is behaving, the way it is infecting, the way it is reinfecting, what are the post-COVID complications. So I fully agree. I think it's very hard to predict as of now that at what level one can, sort of say with confidence that the population may have achieved herd immunity. So with this, I now have a question for Dr. Jain. So Dr. Amita, your lab was one of the early testing centers in the country, and in fact played a key role in scaling up testing across the state. And UP is in fact, one of the largest states with the most number of districts. So, and then there were, a lot of challenges initially. We were hearing and reading a lot in the newspapers that the testing has been slow, and now, it is almost in line with what the other, better performing states are doing in India. So could you please, give us, an insight into, some of the key efforts undertaken by you and the state at large to ensure this massive scale up across the Uttar Pradesh state? Dr. Amita, you're on mute.
Here you go. So good afternoon, everyone, and thank you, Dr. Sanjay, for the opportunity. I would like the group to know that when we started, that was on 3rd of February, we were the single lab in UP. And I mean, it's no new knowledge that it's the largest state in the country with a very, very huge population. Since then, about 7-8 months have gone, and today we have more than 131 labs who are doing COVID testing. And these are the ones who are doing molecular testing, of which 69 are the RT-PCR labs and remaining are TrueNat labs. So some of the labs are doing both and some of them are doing only RT-PCR or only TrueNat. This includes the labs in the government sector, the labs in the private sector, both. Government labs have really increased in a very, very unbelievable kind of a fashion, the way it has expanded. We have about all the medical colleges in UP, all the medical institutions, even some institutions which are in CSIR institutions, they are not medical teaching institutions, they also have RT-PCR labs and they are providing. Needless to say, a lot of efforts have gone into that. It will be unfair if I do not mention the guidance and the advisories which were coming from ICMR. It will also be unfair if I do not mention the way UP government has committed to testing. And definitely there was a lot of national support which was given to that. Coming to the need, it was on every front. There were no people who knew what is even an RT-PCR, and these are the ones who are doing PCRs in thousands today, 1,000 reactions being run per day. So that was the gain. Need was exponential, and we could see that 1 lab or 5 labs or 10 labs will not be enough for a population like that. So what all we did, initially it was decided that whatever place they have, nobody has an idea that how the layout of a PCR or molecular testing laboratory. So initially a generic map was provided, then these maps were changed as per site, and that kind of input was provided for every lab. They had no idea what the equipments will be required, so equipments were listed, specifications were written. There were a lot of guidelines which were coming at the national level from ICMR and other sources. They were taken into the account. It was made sure that availability was a big issue. Like that was the time when country was going in lockdown and the availability was now not there. People didn't know what kind of expansion we will need. So providing them the alternate options, even connecting them with the potential suppliers was a big job that time. Coming to the manpower, we really didn't have the trained manpower, and that was when time the whole country realized we need the people who can do the molecular testing, which was a huge limiting factor. So understanding that who can do the test, training them, who's trainable, that was again this thing, and the time was a constraint. We didn't have much time in hand, and so doing it really fast was also a challenge. Manpower was trained. Trainings of the trainers were done. So in the regional areas, we had the laboratories who could provide some training. Training was required both for biosafety and the molecular testing. Only molecular testing was not enough, and we didn't have the time to provide at least 1 month of training, which is minimum required. So it was done really, really fast. validation of these labs, providing them the QC, external EQUAS, all this was a challenge and which was kind of done. So coming to that, the civil work, equipment, manpower, trainings, validations, making the reagents and equipments available to them, all of this was a challenge. And I'm happy to say that today we have 131 labs which are working. For new labs, I'll say that quality of testing is most important, biosafety is of concern, and maintaining the turnaround time, which Dr. Gagandeep has also mentioned, is very, very essential. If we provide a report after 7 days, that carries no meaning in today's time. So that's from me. Yep.
Thanks, Dr. Amita. I think from the outside, it seems also simple, ramping up to 131 laboratories in a matter of few months, enabling access to, the population and across the districts. And it's really, it's really been quite an effort. And, not just, Uttar Pradesh, but I think across the country, it has been quite unprecedented. And the way the country has risen to it, starting with a few thousand tests in March to now over 50 million tests, I think it has been simply amazing to that extent. And we are very happy from a Pine perspective that so much focus, on the diagnostics. And then almost everyone in the community is realizing that it is very critical to continue to focus on diagnostics. We only wish that, this is something which is carried forward for other diseases also. And then there is a lot more use of diagnostics as has been so far. So I think Dr. Jaiswal is still not there. So I have another question for Dr. Kang. And then, while we were hearing to some folks from WHO, and while they're all saying that so far there haven't been any major mutations to sort of any major implications on the development of the vaccine or let's say the diagnostics. But I wanted to hear from you that, what could be the possible impact of such mutations as we continue to put in efforts for the development of newer tests, and more importantly, the speed that is being put behind bringing a vaccine to the market?
So I think we've actually been quite lucky in the SARS coronavirus too, in that it is a coronavirus that mutates quite slowly. There are many other RNA viruses that mutate faster than this virus. So we need to continue, like we do with many other RNA viruses, influenza, RSV, rotavirus, we need to continue to track this virus and make sure that when there are mutations, we pick up those mutations. And we can do that by sequencing the virus and figuring out what is changing where. The problem with a test like PCR is that if you get a mutation in the primer binding site, you are going to wind up with false negative tests. So particularly looking to see that there are no mutations in the sites that we are using for amplification. We are using multiple genes. And that's very important because it gives you a backup strategy. So even if there is a mutation in the primer binding site for one particular gene, you can still pick it up with the other genes. So definitely need to track. So far, no indication that the mutations affect test sensitivity, but it is feasible that something like this could happen. Now, PCRs are tests that depend on amplification of nucleic acids. So it's really the sequence, the genetic makeup of the virus that we need to track. But when you have a genetic change, that can lead to an antigenic change as well. And in the rapid diagnostic tests, what we are doing is not an amplification, but looking for the presence of proteins of the virus. And if that protein structure changes, the antibodies that we use for capture may not be able to detect the virus anymore. So making sure that we continue to monitor what is going on with patients with collections of isolates, with sequencing data, with studying antigen structure is all very, very important to ensure that diagnostics remain fit for purpose. We've done an incredible job so far, but it will not be complete if we do not continue to monitor both the genetic sequences as well as the antigenic makeup of SARS coronavirus 2.
Thanks, Dr. Kang. I also had a follow-up question on that. You know, if you want to say a few lines about the country efforts around maintaining this vigil around the potential mutations to the virus and all the other efforts that are needed to ensure that we, you know, the diagnostics stay fit to purpose.
So I think it's very important to recognize how quickly and how much work has been done on the sequencing of the virus and continuing to track it. From the first sequences being available from the National Institute of Virology and then subsequently starting to see sequences come out of Gujarat, now we have thousands of viral isolates from India that have been sequenced. These are efforts that have been led by the Department of Biotechnology and the Council for Scientific and Industrial Research, as well as by individual academic and public health organizations across the country. Many of these sequences have been contributed to a global database, GISAID, which was established for influenza. And the fact that we have a tool like this allows us to continue to track these viruses around the world and understand India's place in the world. This is very important in a pandemic, that we contribute our knowledge to make up the whole picture of virus circulation. The other reason why sequencing is very, very important is because sequencing allows us to look at reinfections and to understand when you have a person who tests positive the second time, is there a possibility that this virus is one that could be latent, or is this really a reinfection? Sequencing has shown us from data that came out from Mumbai and from Delhi from healthcare workers that reinfection due to different viral strains is happening. So they were picked up by PCR, but ensuring that it was a reinfection and not a reactivation of the virus really came from sequencing data.
Thank you so much, Dr. Kang. Now, I had another question for Kayla. So Kayla, pandemics like the one we are currently experiencing, you know, they underline the need for global collaborations. And as I said, you know, originally just before the start of the panel, I think there has been an unprecedented effort around, you know, having such collaborations and sharing of best practices. You know, I mean, if you could share some light on some instances of positive global collaboration to ensure that strategies, the scientific know-how, and the resources, you know, are being equitably shared. Yeah.
Sure. Thank you. Well, I think there are many instances of this, but I think one of the most exciting ones that we've been part of is the access to COVID-19 tools, or the ACT-Accelerator, which is for diagnostics, vaccines, and therapeutics. And it's many different organizations, Gavi, the Gates Foundation, CEPI, all these different organizations together kind of helping to fund it together and to really ensure that as new diagnostics, new treatments, and new vaccines come to fruition, that there's equitable access and access to populations, access to scientists, that there's opportunity for everyone to learn from each other and to have access, which is really important. There's been some really important analyses done about the distribution of vaccines, how important it is that everybody has access across the world. Of course, India will be a major player in that. And so I think that kind of collaboration, there's been a lot of cross cross science collaboration, people working together when in areas that maybe they hadn't worked together before, sharing of data, sharing of scientific knowledge, and moving things quickly. I think even the number of labs, as Dr. Jane was saying, all the different labs being qualified and coming online so quickly, having that kind of quick collaboration and quick approvals, both within the country and externally, to make sure that things start moving as quickly as possible and the data are shared and science is shared, is what really has been unprecedented, and I think is a huge example of what I hope will continue, long past COVID-19, because it's a great example of collaboration and working together. And the first vaccines out the door will have been, really a multi-country, multi-scientific collaboration, and we'll need everyone's participation to succeed. And that kind of working together where everybody really wins doesn't always happen. And I think we've seen it with COVID-19 in a way that we've maybe not seen it before, and certainly I hope will continue long past COVID. But I also think we've, learned trials also, maybe some of not only the vaccine trials, but some of the epidemiological trials that WHO has been spearheading, that many scientists, including many in India, including Dr. Kang, are part of, have also been sort of a really nice way to collaborate across many countries and look at serological studies and epidemiological studies, transmission studies, in ways that really brought everybody together and created a common platform. So I think there's been many opportunities with COVID and a lot of growth in that kind of global health collaboration that hopefully will continue. Thanks. Sanjay? Can anybody else hear me?
We can hear you, Kayla.
I think Sanjay's connection is little.
Oh, okay.
Stable, maybe. Yeah.
Okay.
So I'm sure.
Does anybody else want to add to my answer? Oh, there's Sanjay.
I think one of the things we could do until Sanjay comes on is answer some of the questions. And Dr. Vidya had asked a very interesting question about COVID-19 reinfection and whether herd immunity can help to flatten the curve. I can see Sanjay's back on now, so perhaps we'll go back to the Q&A, and then I'd really like to take Dr. Vidya's question.
I think Dr. Kang, you can go ahead and answer. I mean, there's no fixed format we have to follow.
Sure. So in terms of reinfection, one of the things that's very important to understand is that reinfection does not mean re-disease. Many of the people who are infected the first time and the subsequent time will get infected without having symptoms. The ones that we need to worry about are the ones in which you see infection and disease more than once. And it's very clear, even from the reinfections that have been reported so far, that there is only one example of somebody who was reinfected and was symptomatic both times without having any comorbidities or anything else. I don't think this virus is that unusual. It does have some unusual features in how it affects the immune system. It seems to be provoking some level of autoimmunity, but this is not HIV. It's not completely destroying the immune system in everybody that it infects. It is a mucosal pathogen for the most part in most people, which means that reinfections will continue to be found to be common. When we look at respiratory and gut pathogens, we know that reinfections happen all the time. But disease becomes less. The more times you are infected with the virus, the less severe disease becomes. Even for something that is as imperfect as influenza, that doesn't give you perfect protection, where the virus changes a lot, you still see, if you've had exposure to certain types of influenza viruses, you have some degree of protection when you see the virus subsequently. So I think flattening the curve is really about stretching out the number of cases, and to do it in a fashion that allows the healthcare system to cope. So we are talking about a couple of different things here. One is the idea of reinfection and whether you get subsequent protection from disease. I think yes, you will. And that's what vaccination will also give us. It will give us protection from disease. It may or may not give us protection from infection. Now, when it comes to herd immunity is a different concept. It is if you are part of a group that has a lot of exposed people who are not susceptible to infection, then transmission of infection slows down. And you have people indirectly protected because of the high levels of exposure in that group. It's important to remember that when you come out of the herd, you're no longer protected. If new people come into the herd, then they get indirect protection as well, but they dilute the percentage of infected individuals. So there are lots of things at play here. And as I said, flattening the curve is slowing down the incidence of cases that result in infection and disease, such that the healthcare system can cope with them. So I hope I've addressed your questions. Essentially, very important to remember that reinfection does not mean lack of protection. Oh, back to you, Sanjay.
Oh, sorry for the technology glitches. Sometimes technology fails you when you need it the most. So apologies once again for that. So I don't know if there are any other questions, but I just had maybe, a couple more. I think I at least had one question for Dr. Jain. So Dr. Amita, there's a widespread discussion about the CT values and its importance as a predictor in transmission of infection. Can you please throw some light on whether this should be considered and clarify the correlation between CT values and infectivity?
I think, Sanjay, for the participants, they have to understand that CT just denotes it's the number of cycles, a threshold at which the fluorescence becomes detectable by the machine. So theoretically, if we look at it, CT value is inversely proportional to the amount of genetic material in a reaction or in a sample which is present. So if we say low CT value, that means we think that viral load is high. And if we see high CT value, it means the viral load is low. Some of the researchers and some of the clinicians thoroughly believe that if there is a high viral load, that means patient or person has a high infectiousness and high severity of disease, which I would like to say that there are some studies which are talking about it, but there are no reliable studies which definitely prove that there's a direct correlation between severity and the CT value, either or the infectiousness and the CT value. Reason being, if we look at it, the logic behind this statement will be that firstly, that CT value varies from kit to kit. Every kit doesn't give you the same value. Reason being that the amount of the gene which they are picking or the amount of material which is present in that kit particularly is different. These kits are designed to estimate it, yes or no, that they are just qualitative, they are not quantitative kits. Moreover, the samples vary. They are collected, some collected from nose, some collected from the nasopharynx, throat, saliva. Different samples are being tested and the CT values may vary. The competence of the person who is collecting the sample may vary, how much the patient cooperates at the time of collection. So a poorly collected sample may be due to the technical incompetence of the person who is doing it, or may it be to do through the non-cooperative patient, may lead to a poor sample and a bad CT or high CT. Moreover, the person who is putting the test, his competence is also important. He may not know how to exactly pipette. So pipetting mistakes may lead to the variation of CT value, calibration of the equipment to equipment variations also have been seen. So these are the various, how the samples were transported, the temperature at which they were transported, how much time have you taken, because if they are stored at improper temperature for longer period, the CT values will increase and the viral load will fall. So these all are the technical issues. Other than that, it has been very often seen that people who are asymptomatic or mild cases also have CT values which are very, very representative of high viral load. At the time of diagnosis, if you catch a patient very early or very late during that illness, the viral load may come down and CT value will increase. So all these are the factors which make us think that CT values may not relate to the infectiousness of the patient or to the severity of the illness. Moreover, as Dr. Gagandeep has already said, that the COVID disease is actually the response of host factors also. It's not only the virus which is kind of invasive, the host factors, the immunity of the host, whether he is primed, how the immunological responses are triggered, all this also leads to the severity of the disease. So saying that high CT value means you are safe and the low CT value means you are very, very unsafe and you are going to have a severe illness will give a false sense of security. So to my mind, this is a qualitative reaction. It just tells you yes or no. It is not designed to measure the viral load. There are many, many variables here which can suggest that, and the experience also says that the severity of illness is not decided by CT value. So at this point of time, till we have the kits which can tell you exactly, which are designed to measure the viral load, it will not be very wise to say that CT value correlates with the severity of illness, even the infectiousness of this person. So that's my comments.
Thanks, Dr. Amitabh, for such a thorough response to this question. I think this is a question which has been posed by a lot of microbiologists, clinicians, and we also have seen a lot of reports in the newspapers. But I think thanks for a very comprehensive response. I have one more question, and I think this is probably for Dr. Kang from a colleague of mine, Dr. Prabhakaran. So Prabhakaran asks, how long do the protective antibodies circulate in the infected persons? I know there has been a recent report, as recent as, perhaps a few days back, where it said that I think they're now seeing up to 5 months. But over to you, Dr. Kang, if you wanted to answer
Sure.
this specific question.
So if we look at the tests and look at the antibody tests, some of them detect antibody to the spike protein. Some of them detect antibody to a part of the spike protein, the receptor binding domain. Some of them detect antibody to the nucleoprotein. There are still other tests that look at antibodies to the non-structural proteins of the virus. So there are proteins that make up the virus itself, and then there are proteins that execute the functions of the virus. So people are looking at those non-structural proteins also. There is a huge variation in who responds to which structural or non-structural protein and how long those responses last. This virus is a little bit strange in that the IgM, classically what happens is you get your IgM response first, and that's usually in the first couple of weeks. Then after 3 weeks, you get your IgG response, and about the same time, you start to get an IgA response. In this virus, it seems like the IgG response follows the IgM response quite quickly, but the duration for which the responses persist depends on the antigen. The nucleoprotein, which is what is used in the Abbott test, antibodies seem to last for a much shorter period. If you look at spike and receptor binding domain, the antibodies tend to last much longer. In addition to the antibodies, which are measured through most of these commercial assays, these antibodies are binding antibodies. They're binding to the protein against which they have been made. There are also neutralizing antibodies that we look at, and neutralizing antibodies require a test that looks at, it's actually a functional assay. Can the antibodies prevent infection of cells by the virus? So you need the wild type virus or a pseudovirus which carries the proteins of SARS-CoV-2 to be evaluated in this assay. Neutralizing antibodies do track with the binding antibodies, but not perfectly. So when we look at durations, it depends on which antibody we've measured, with which test, and whether it was a binding antibody or a neutralizing antibody. And the neutralizing antibodies are the ones that are going to most likely be important for measuring whether vaccines are working or not to induce protective immunity. At the moment, we don't have a correlate of protection. It's possible that the correlate might be a combination of antibody and cell-mediated immunity, but it's important for us to track that. The fact that antibodies don't last forever or don't last above a threshold creates a challenge for serosurvey studies. And the challenge is in two ways. One is, was this test actually designed for serosurveillance, or was this test designed to demonstrate that somebody who was infected made an antibody response? So follow up somebody who was PCR positive, and then you look to see at 3 weeks, have they made antibody or not? Even within immune responses, they are biphasic, and the calibration of the test to be able to measure either the acute response or the prolonged response needs to be structured appropriately. Most of the tests that we have currently are measuring the acute response. So we may want to think about, are they really fit for purpose for serosurveillance studies?
Thanks, Dr. Kang. So I hope, Prabhakaran, that answers your question. There couldn't have been a more comprehensive response to this, question around protective antibodies. I have another question, and perhaps Kayla, if you could take a shot at it. I mean, is there any evidence to say that certain individuals are more genetically predisposed to get affected by COVID?
So I think there are, there's a lot we don't know. I wanted to actually make one additional comment to Dr. Kang's points below, related to the first question you asked me, because if serosurveys are being done with a test that isn't fit for that long-term surveillance measurement, that's really important for this question of, well, we're doing serosurveys and many people are infected, and so is everybody infected, and are we at some threshold? Because actually going back sometime later and measuring the same population, that prevalence may go down because of those antibodies waning. And what that actually means in terms of their protection from a new infection or disease is not known. So it's just an important additional point that if it's not a test that's really perfect for serosurveillance, down the road, we may not be measuring everybody who was infected because of antibodies waning, et cetera, depending on the test, just to kind of underscore what Dr. Kang just said. So that's important when we're doing serosurveys. In terms of, there are definitely each day more and more information, more scientific information coming out about individuals, their own genetic makeup, their own cytokine makeup, their own, immunological system. And so certainly not everybody is equal when facing this virus. In addition, there's, mixed data on what your previous exposures have been to other coronaviruses or to other illnesses, as to what how you may respond to COVID-19. And so I think that there's a lot of study that needs to still be done in terms of host factors. We certainly know that comorbidities and age and various factors are risk factors for more severe disease or death. But in terms of many other genetic factors and pre-exposures, and why certain population may not get as ill as a different population is still kind of under discovery. And I think that we'll learn quite a lot in the next few months to a year as to what are all the related exposures and risk factors for each individual's kind of response, not only to getting infected, not only to having a severe disease, but also those individuals who are called long haulers, which are people who stay somehow ill for a very long time, have some kind of comorbidity or sequelae for a long time. What are those risk factors and what leads to that are also still under a great deal of study.
Thanks, Kayla. I have, one more, I think time for just a couple more questions. So I think probably for you, Dr. Amita, I think all of the antigen tests currently, we are using the NP samples. So there's a question that is it possible to develop an antigen test with blood as a sample? If you can unmute yourself, Dr. Amita.
First, I'll unmute. Yeah, keep forgetting it. So I will say this is a respiratory virus. So it's mainly on the respiratory mucosa or maybe GIT or sometimes kidney and all. So organ involvement is not as common. So we may find a virus in the blood at a later stage of infection. I think the best sample here will be a respiratory sample, not the blood sample. So blood is good when we want to estimate antibodies or response of the body against the virus. But for estimating the antigen, I'll go ahead with the respiratory specimen because it's a respiratory virus found in the respiratory mucosa. So the first place where we can find is the respiratory tract, and the maximum number of the viruses also be in the respiratory tract. So I don't think blood will be a good sample.
Thanks, Dr. Amita. I think we are coming to the end of the panel. One last question, and that's also for you probably, Dr. Amita, is does the time of collection of nasopharyngeal samples, does it have a role as far as the viral yield is concerned, or the result of a rat test? I know for rat tests, there are manufacturer recommendations. Obviously, for example, Abbott recommends that you test the sample within 2 hours of collection. But from a PCR standpoint, do you feel that the collection and I guess the transportation of samples will have a bearing on the viral yield?
So definitely, so why not? Because see, if a patient is in the early stage of infection, so we have to understand the cycles of the viral infection or the whole cycle of one case. In the early stage of infection, when we have more viral load, the chances of picking up, especially by the antigen test, will be more. We might miss it when we get a patient later in the stage of infection. So definitely the time at which the virus or the swabbing is done from the patient has a bearing on your test results. If you swab a patient very early or very late, you might miss it. But still early is better than the late, because in the later stage, you may miss it. Antigen positivity is best in the first few days, 2 to 3 days of infection. After that, the positivity decreases if the viral load goes down. So definitely the stage of the infection has a bearing on your test results, both RT-PCR and antigen, more so on antigen.
Thanks, Dr. Amita. So I think we are coming to the end of the panel. I wanted to take the opportunity to once again thank all our panelists. We missed Dr. Jaiswal, of course, but I think this eminent panel really was able to answer all of the questions so comprehensively. For me personally, I've gained a lot. I think it's been a lesson in microbiology, immunology, and epidemiology all combined. So thanks so much for educating all of us. So with this, we'll come to an end of the panel, and wishing you all a great weekend. Thanks once again, and stay safe, everyone. Thank you so much.
Thank you, Sanjay. Thank you, Dr. Gagandeep, and both. Nice seeing you all. And thank you to all the participants for bearing us for that long. Thank you so much.
Thank
you so much. Thank you. Bye.